Thank you very much for inviting me again to talk about this. I retired a month ago, so I'm recently retired, but I'm still active in the field. Um, and I'm very pleased to be able to talk about my favorite topic, which is arm function. And arm function, well, the arms are a very important part of our body. Of course, we're all thinking the whole day with our head, but if you look at the arms or the legs, then the arms are much more used than the legs. So, one of my earliest focused in the studies I performed were not on walking, but on arm function. So, and I now I see an increasingly interest in the arm function, and hopefully it will continue also around the world to get more focused on arm function because the majority of the lifetime of a young man or an adolescent or a young man or even an older man with Duchenne is in the wheelchair, and well, he's dependent then on the arm function. Just to get things clear, um, this is a picture of the arm muscles, and I point to the most important one for you, which is the deltoid, which is on the shoulder. And the deltoid can be divided in three parts: the anterior part, which is on the front, the middle part, and the posterior part, which is on the back. And we can also see the triceps over here and the biceps on the other side, which is in the front of the arm, and this is in the back of the upper arm. These muscles are very superficial, which means that they are just beneath the skin. And that makes it possible that we can record when they contract their electrical activity by means of surface electromyography. So you can see a picture around here with two electrodes on the biceps. And when the person contracts, you can see a bulb of activity on the screen. And when we asked the participant to make as much strength as possible in this posture of the arm, then we can actually measure the maximum voluntary contraction activity. And what we did in our research is that we related muscle activities that we measured during making movements to the maximum voluntary contractions in a percentage. So the maximum voluntary contraction is 100%. And if you're using less muscle activity, less activated muscle fibers, then you get a percentage of that. The problem is that we only measure the maximum voluntary contraction and the EMG, the surface EMG, in one position. And if you use the muscle in different position, for example, with the elbow extended, then you can measure different maximum voluntary contractions, but we only use one in the preferred position. So if we go to the next slide, you can see what we did. We placed boys with Duchenne in a movement lab, and we looked at them with all bulbs on their arms, and these bulbs reflect light, and with different cameras we can see uh, in which direction the arm moves, because all those different cameras uh, detect different form of light, so that we can actually know where the arm is in the 3D room environment. And we combined this with the surface EMG, and we asked the boys to perform some activities. So we asked them to uh, lift their arms sidewards, which is called abduction, or flex your elbow, or to reach to a specific point where they could reach to a specific point that we placed in front of them. But we also asked them to do unstandardized measurements, non-standardized measurements, like drinking, and they were allowed to do it in their own way, or moving a weight on the table from one side to the other side, or draw something on the paper. And these three are non-standardized movements, while the first three were quite standardized. And what we could see is, if we look at the patients, which is the dark one, then we can see that, for example, while lifting the arm sidewards, which the deltoid is responsible for, we can actually see that the more than 100% of this deltoid muscle is used, while a healthy boy is using about 60%. And if we ask them to reach forward, then nearly 100% is used. So the boys with Duchenne use a lot of more of their muscle activity to perform tasks, standardized and but also in non-standardized tasks. And the effect that they are lower in a non-standardized task is the effect that they use compensatory muscles, which we can also see in the next slide. This is again the movement we asked to perform is the sideward lifting of the arm. And we can see in the blue bulbs that the boys with Duchenne use a lot of muscle activity, sometimes very high, while the healthy boys use less. So the red line over here is the healthy age-related boys, which is the mean of those. And you can see that the mean line of the Duchenne boys activation is around 100%. So they're using quite a lot of more activation of their muscles. Actually, they're using all of their muscle fibers to perform some tasks. And this is very important to remember because you cannot do the whole day a maximum muscle contraction. You can only do it once or twice, and then you have to rest and rest. And then perhaps a couple of hours later, you can do it again. Nobody is able to run a marathon each day. This is comparable with the muscle activation in the arms of the boys with Duchenne. But we saw another thing. We saw that while lifting the arms sidewards, we saw in the Duchenne boys quite a lot of activation of the biceps, which is a muscle on the front of the forearm, of the upper arm, which is, and we also saw that what the anterior part of the deltoid is used. So these are two compensatory muscles which are used. And we already saw that in clinic because when we asked the boys to lift their arms sidewards and they are doing it normally, then we gave them a Brook 1 scale. But if they are bending their arm to lift their arm, we give them a Brook 2. And these two muscles, the biceps and the anterior part of the deltoid, are responsible for the compensation to perform that and thus the bending of the arm. So this is in a movement lab, but if we look at home, we measured at home during a couple of days, 7 days during a week, and we asked to wear accelerometers, which are very small devices that are like a matchbox and also very light on the upper arm and the lower arm. And we counted how many times the boys were in the lower part of the arm movements, which means that they are on the table level or the blade level of their wheelchair, and how much they were on the middle section. So say from table to half the shoulder or to the shoulder section. And you can actually see in Brook 1, then the boys are actually lifting their arms quite a lot. But when you see the disease progressing and we come to less muscle power, which is reflected in the Brook scale, because in Brook scale 4, you're not able to lift your arm anymore, and you're not able to lift a glass to your mouth when you're supporting your elbow on the table. They can actually see that most of the activities of these boys were on table level. So it's very difficult for them. It costs a lot of energy, but it also decreases in the extent that they are using the arm to in the 3D movement. And the changes between the low level. Oh, sorry. I want to go back. The low level of this to the middle level is in Brook 1 still possible, but you actually see that there is no changes anymore to the high level anymore. So the boys are using the arms less and less, and if they use the arm, and they can even reach upper limits to the shoulder level, they can do it only a few times a day because it's very fatiguing. But the fact that you're not using your arm that much in different directions means that the arm becomes stiffer. And in a questionnaire, we asked more than 200 boys and men about stiffness and give it a number. And we could count how much stiffness there was experienced by them during the disease stages. So you have the early ambulatory stage, the late ambulatory stage, the early non-ambulatory stage, and the late non-ambulatory stage. And this is, well, they experience some stiffness, but not much, but it's increasing. And while in the late non-ambulatory stage, it even is black, which means that they experience quite a lot of stiffness. But combined with this stiffness, we also saw the increase in pain in their arms. So you actually can see that also the pain intensity and frequency is rising during the stages. And we do think that this is responsible also due to the stiffness of the arm. So one of the things you would want from these boys and men is that they can move their arms in a quite normal way, supported, so they don't need a lot of muscle strength, but they can still use their arm. So it will decrease the stiffness and will decrease the pain, but also will decrease the dependency, because if they can do much more themselves, then they are less dependent. So what do we know until now? Well, we all know that the muscle strength is already lower than the healthy controls, and that most of the activation in nearly all the tasks is 100%, which means quite a lot of fatiguing during the day. And that pain and stiffness decrease the performance of the arms. And we know that also from the same study of Mariska Jansu, which I described on the last slide, that the restrictions in participation and social activities were due to arms were increasing during the stages. And we also know that there are compensatory muscles that are activated during the performance. And you can see a nice picture of the boy that is showing those compensatory mechanisms. He's bending his arm just to lift him to shoulder level. But you can see another thing. You can see that he's also bending sidewards. He's bending to his right side, enabled to lift his arm. So it's not only compensatory mechanisms in the arms, it's also a compensatory mechanism in the trunk. And if we look at more sophisticated ways to see that, we did the same experiments, but that with bulbs on the trunk of the boys and the men, and asked them to lift their arms in a structured way, and also with a non-standardized drinking and moving a plate. But you can actually see it in the front plane, which is the plane where you look in the face of the boy, that the sideward bending is quite a lot in the back. So in all movements, but especially with these movements, and these movements are reaching far. So the farther they were asked to lift their arm or to reach, the more compensation of the trunk is necessary to do it. And it's not only the movement, but it's also the muscle activations. Again, if you look at the darker green bars, then you can see that the muscle activation of the trunk muscles, the back muscle, and the abdominal muscle is much higher than the yellow ones, which is the healthy controls. So it's not only the arms that are fatiguing, it's also the trunk that are fatiguing during the day and during all arm activities. Well, I want to explain something about this picture, because you're looking now at a boy with Duchenne. It's not one of mine. I just picked it from the web, but it's very illustrative, I think. The boy is happy, but I'm not very happy about him, because you can actually see that he is leaning on his side where his joystick is. And the next thing which is obvious is that his feet are not very good positioned on the feet rest, that he has an open book posture where his hips are abducted to the side, and he is slipping a little bit away in his wheelchair. And he's not able to stabilize his position this way because you can see that he's holding his left arm between his armrest and his trunk. So he's stabilizing himself by putting his arm over here. But that means that he is not able to use the arm. So there is a disuse in this arm just because of the fact he's not stabilized sitting in his wheelchair. And in a former presentation 2 years ago, when we could meet each other and see each other again, well, I talked about this, and I talked, well, a bad sitting position um, is of negative influence on the heart, on the lung, but it can also cause pain, and it can also cause scoliosis, but it is also influencing the extent of the arm activities. So it's not only the trunk we have to stabilize, we also have to stabilize the legs. And this is necessary to make excellent use, the optimal use of the arms. So the solutions I gave you 2 years ago were stabilize the feet on the footrests by shoes above the ankle. And if you look quite good at the picture I showed from the happy boy, he had low shoes. So he had not ankle high shoes. The next thing is to place the legs in a good position by giving them these knee pads so the legs are not in an open book position and he is not slipping away from his wheelchair. And there is also a possibility to support the trunk more by side rests. And if there is a pelvic obliquity, which means that the pelvis is not in a horizontal plane, then you can correct the pelvic obliquity by adjusting the cushion he is sitting on. This all helps to stabilize him sitting in the chair, but it also helps to improve his arm function. And there are some commercial arm supports available right now, and I only showed two that I also picked from the web. One of the Netherlands, which is called the GoWing, and one of USA, Jayco. And if you look at those, they seem promising, but you can also see that they are only on one side placed of the body. And if you look at this picture, the down picture on the right side, you can see that this boy is already leaning on the armrest. And there is a risk that if you only give one arm support, then there is a risk that there is a scoliotic development due to the fact that they are leaning on their arm support. But the problem with these arm supports is that if you give them on both sides, they are not stable enough because they're floating the arm and they are not stabilizing the arm when, for example, you're riding a wheelchair. So it's limiting the use, but it's also limiting the possibilities to use your arms during the whole day and also during and having a good posture and sitting posture while performing all kinds of activities when the arm rests are in use. And we are working on a new type of arm support, which is called the human arm. And this is placed on both sides. And one of the things we saw when testing it was also with all kind of movement lab measurements that the trunk was quite stable in the midline in the position. And the boy didn't need to lean over to lift his arms sidewards or forwards with his trunk. So the trunk was much more in the middle, where it's a non-scoliotic position. Well, the manuscript is now in revision, and it's written by Mariska Jansen, so probably you can read it in a couple of months. But my plea is that you should look at the stable sitter position in the middle, and if you can reach it by arm supports, it doesn't necessarily mean that you should use the human arm, but perhaps other arm supports that can be locked so you can have a stable position while driving the wheelchair would be essential. But don't use much the one-sided arm arrest, because then you're actually uh, dealing with the fact that you're in a scoliotic position. Well, we're also working on the development of new prototypes, actuated prototypes. This is a very old picture. I saw today the new ones, the new prototypes, but I wasn't allowed yet to show them. But it will be fancy, not as fancy as this one. There's the robot man on the in the gold exoskeleton, but it's it's closing the gap between the use of the arms themselves, the boys, by just weight support, just so weight make the arm weightless, the which is the what which you could see on the former slide, to deactivate it with small motors on the side, where also older boys and men can make use of it. And this would be one of the solutions we could give them when we ask them to move to all directions in all ways and train their arms still during daily activities. But we need to support them, because using without support will mean that they are fatigued at the end of the morning, or already at coffee time. So I thank you for your attention. I'm ready to take questions.